Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Rhiannon Ashman, Deputy Editor of MIMS Learning, and October is Breast Cancer Awareness Month, so this will be the focus of today's episode. Now, according to Cancer Research UK, 1 in 7 women in the UK will develop breast cancer during their lifetime. It's the most common cancer in the UK, but survival is generally very good, particularly if the cancer is diagnosed early. And supporting primary care with early detection of cancer is, of course, the thrust of MIMS Learning's editorial campaign this year. So I'm delighted that my guests on the podcast today are from 2 of our campaign charity partners, Future Dreams and Breast Cancer Now. We'll be talking about how to answer questions from people with suspected or newly diagnosed breast cancer, taking a family history, when to refer for genetic testing, as well as signs and symptoms that may indicate secondary breast cancer. We're going to hear from 2 women about their lived experiences of breast cancer and the impact that primary care have had, as well as some tips on things that could be done differently in practice. So first, I'm pleased to welcome Jackie Wright and Amanda from Future Dreams, a charity that provides in-person and online support for those diagnosed with breast cancer, funds research and promotes breast health awareness. Jackie is lead clinical nurse specialist with over 25 years of experience supporting people affected by breast cancer. Amanda is Future Dreams Support and Awareness Ambassador. Following her own diagnosis of breast cancer and experience of treatment, Amanda left a career in teaching and has been working at Future Dreams for the past 6 years, raising breast health awareness, promoting early detection and supporting others also affected by the disease. So welcome to both of you.
Thanks for having us.
Thank you for having us.
To start with, Amanda, could you tell us a bit about your experience of being diagnosed with breast cancer? What were your symptoms?
For some time, I'd been noticing and feeling, I can only describe it as kind of a long, fatty lump just sitting at the top of my breast. And my hand would go to it. And my thoughts were at the time, I was 42 years old. I had twins, body shape had changed, breast shape had changed. And I remember thinking, nothing to worry about, there's nothing in my breasts. What I would have imagined would have presented as a possible issue problem, like a small lump, I was just feeling this long, kind of fatty area. And not concerned at all, I found myself at our family GP for an appointment with one of my children. And she was writing out a prescription for him and just by way of making conversation said, "And how's mum?" So I said, "Oh, I'm fine." And really just to fill in the gap of silence, I said, "Oh, I've been noticing this fatty lump on one side, on my left side, just at the top of my breast. Maybe if I come and see you about something, take a look at it for me." And our family GP was extremely proactive in, at that moment, asking my child to leave the room and said, "Please just remove your upper clothing and let's have a look at what you've been noticing. Let's take a look." So first thing she did was ask me to raise my arms in the air. And as I did that, I noticed, and she noticed, changes in the shape of my left breast in comparison to my right breast. And these were kind of like skin changing issues, and it looked like something was drawing in on around the nipple area. It just looked different to the right side. And she said, "I'm going to make a referral to our local breast unit to get this checked out." And I can honestly say that I actually mentioned to Jackie this morning, I don't think there was anything else after that I would have made an appointment to go and see her. So my GP saved my life.
That's really encouraging to hear that your GP was really proactive and, like you've described, perhaps not the typical symptoms that a patient might be concerned about, but obviously alarm bells were going off for her and she was really responsive. So that's great. Was there any area in your interactions with primary care, maybe subsequently, that you felt like could have been improved?
Well, I think at that point, you have referral into the breast unit, and then I had the subsequent breast cancer diagnosis and treatment, where I was looked after by my breast team. And I think the communication with your GP kind of stops at that point. And until then, they are your main primary carer. One thing I would have liked during that time was to have had the option to see the same GP so that I wouldn't have had to explain what had gone on. I was trying to process so much. No one prepares you for a breast cancer diagnosis. You know nothing about breast cancer. So I think to have had that continuity of care with the same GP that I didn't have to explain each time, and it was a traumatic period to even talk about it. I just remember having a box of tissues in front of me constantly. And yeah, I think looking back, I kind of felt that I had to navigate through that myself. And we're going back 12 years. So I think at that time it just felt like I was navigating through a fog of the unknown, really, and just trying to find my way and find that support.
But I don't think that's changed very much, because we hear that from the people that visit us here. It's going to a GP and having to retell their story to somebody different. And I have people that now carry letters because so much has gone on with their cancer diagnosis. They forget bits, so they actually have to write it out and have that letter. So the idea, in the ideal world, it would be great if they could see the same healthcare professional when they are having those interactions. That would be the same in secondary care, seeing the same surgeon and that kind of thing.
So we're talking about perhaps visiting your GP for an unrelated issue, as well as perhaps for anything related to your treatment.
And I think that's important, where people, even after they've completed treatment, it might be a cough. I remember when you went last year, so Amanda had cough for a bit and, ended up making an appointment to see a GP. And it wasn't until Amanda explicitly said that she had breast cancer 12 years ago that she was then sent for an X-ray. I mean, for me, part of my role here is teaching people to advocate for themselves and not just assuming that every time you go in to the GP that everybody's going to know your history. Also for them to be aware of their signs and symptoms of what they kind of need to speak to healthcare professionals about.
Yeah, definitely. And I think it's through my role at Future Dreams that I'm armed with the knowledge to know that I have to use my voice. I have to self-advocate. And the other thing as well is that I had my left side lymph nodes removed and a left breast mastectomy and reconstruction. And the obvious arm that I think GPs, nurses, whoever would always go for your left arm to do a blood test and blood pressure, vaccination. And for 12 years I've had to say every time, and sometimes I worry that I'm going to forget to say, oh no, please don't use the left arm. I am at lifetime risk of lymphedema. Can you use my right arm? And I'm always surprised that it's never said to me, oh, we can't use your left arm because of the history of surgery on that side. And it's not a complaint in any way, but sometimes I do feel that responsibility lays on me. And what if I forget one day? I'm going to be in a whole panic. I'm sure I'm hopefully not going to get a lymphedema, but these are the things that I can control. And I just feel that when I'm in that setting where there's a medical professional, that could sometimes be taken off me, but that's okay. I'm happy to share so that I get the best care possible. But I think there's little things just to be aware of. With 1 in 7 women diagnosed, there's a lot of breast cancer patients. It's just that there's little things. Just check, what side did you have your surgery? What side would you like me to do your blood pressure? Take the blood test for you. But
I have had many panicked calls where people have forgotten to advocate for themselves and had blood pressures or a blood test taken from the affected side. And whilst the risk is low, it's still there. So, I reassure them that one blood test or one blood pressure is not the end of the world. But some people have what they call white coat syndrome. So actually going into any healthcare setting increases anxiety for a multitude of reasons. So some people do forget, and it's just kind of providing that reassurance. But it is, it would be nice to be sort of a two-way conversation.
Yeah, but that actually leads us onto another point, that whenever I'm in the surgery, my blood pressure goes up. So sporadically, I've got an amazing nurse at the surgery that every so often checks in with me and asks me to take my readings at home for a week. And they're always okay. So we've established that because of what I've been through. And I think just having that understanding, when you've had that diagnosis, suddenly you develop a health anxiety that is lifelong. And so just walking into the surgery, you're going to get anxious. And I think having that understanding, because sometimes I have to say, I'm okay, but I just get anxious because of. And I think, if a GP said, I understand that, coming to surgery with everything that you've been through, I think you're going to feel anxious, your blood pressure's going to go up a bit. Whereas I have to explain that. And that's okay, because you're talking about communication. But I just feel that understanding is just priceless. If someone said that to me, I'd probably relax and just think, I'm comfortable. Yeah.
And I think every time people step into a healthcare setting, particularly primary care, and they've had a cancer diagnosis, they worry. It's a lifelong fear that the cancer is going to come back at some point. You know, statistically, that probability is low, although we do know that 70% of all primary cancers will go on to develop a secondary cancer at that time. So naturally, that anxiety is going to be high, even if it is a cold or something very, minor. That worry is always there, whether they're going to be told that it's progressed or it's come back or whatever. That never leaves, I don't think.
No, I mean, even just having this conversation, I'm feeling my anxiety come up. Just thinking about myself there, I go back to that moment every time, and I have tools and anxiety management things that I use on myself and my breathing and all the things that I've found to help me manage, but still with everything, no one can take that away. I'm always very frightened when I go and see my GP, even if it's for a cough or whatever it may be, that fear comes up in me.
So acknowledging that would feel like really good care for you. Yeah. Do you mind me asking, Amanda, about whether you had any family history of breast cancer? You mentioned it really came as a bit of a bolt out of the blue to you.
Following my own breast cancer diagnosis, a few years later, I think about 3 years later, my mum had breast cancer. And after that, my father had melanoma skin cancer. I was the first, and I was 42. So at the time, when I was asked, is there any history of cancer? My immediate family, no. But there has since been found to be.
And you were genetically tested when you were diagnosed?
Yeah, I was genetically tested when I was diagnosed, and initially for the BRCA gene, and that came back negative. And then as we went on and more cancer did develop and the tree kind of grew, I was then put forward for the recent panel that they do, about 9 different,
it's 9.
Yeah. And that again came back negative. So we have a lot of cancer in the family. I was diagnosed at 42 years old, but there's so far they haven't found a genetic link to why.
But I think for you, what that's done, particularly for your sister, is allowed her early access to family history screening, because even though there's been no genetic link, touchwood today, it's allowed your sister to access the national screening program earlier, which for her is a good thing. So, because we know that early detection can save lives.
Yeah, absolutely. Through her GP, she has mammograms early. She started them very early because both myself and my mum had breast cancer. So it opened the conversations.
And I think that's important, isn't it, within families, is to open those conversations, because particularly with breast cancer, we're not just talking about the BRCA1 and 2 nowadays. As you said, when you were first diagnosed, it was 2 genes we were looking for. 10 years later, we're testing for 9. So it's asking individuals to have the conversation around breast and ovarian, but also prostate and pancreatic and melanoma. I spoke to someone last night, we had an event here, and her father had diagnosed with prostate 3 years later with pancreatic. There's no other family history. They've since gone on, her and her sister being diagnosed with another genetic mutation which increases her risk. So they're now contemplating risk reducing surgery. So it is worth encouraging people that you see in primary care about their family history. And they may not know, but I think it's about encouraging them to open those conversations amongst family. And it's incredibly hard. Some ethnicities will not talk about cancer. It's a taboo subject. We haven't even got the word for cancer. So I think it's very hard to create and break down those cultural barriers. But it has to be. Cancer's increasing year on year. We have to be having those conversations, as uncomfortable as they may be for people.
It's life-saving because knowledge is power, and if someone does need to take action, they're going to know earlier, sooner rather than later.
Before a cancer diagnosis,
Before
hopefully.
a diagnosis, yeah.
Right.
And that is what I want for my sister. Hopefully it will never happen to her, but armed with the knowledge that both her mother and her sister have been diagnosed with breast cancer, she is doing the best to look after herself in the best way she can.
Yeah, absolutely. And what's the latest guidance for primary care around if people are requesting access to genetic testing?
It's really hard at the moment. So we know for breast cancer particularly that statistically the sort of figures are around 10% of all breast cancers will be genetically linked. So the other 90% we say is sporadic, and they can happen for a multitude of reasons. So in the UK currently, we only test those with an active diagnosis of breast cancer. So Amanda in her case. If they then turn out to be positive, then the rest of the family can then be offered genetic testing. There is currently a program for the Jewish community. It's called Genetics, and they can be screened, and that's simply going on to the genetics website, and it's a J, not a G, requesting a swab. They scrape the side of their mouths and with saliva, and they kind of send it off, because we know Ashkenazi and Sephardi Jews have an increased risk. So it's trying to catch those early. But that closes at the end of October. So if we can catch people throughout breast cancer where there's of that heritage and actively encourage them to take part in this project, that would be amazing. But if the person with a cancer diagnosis has been genetically tested, but like Amanda has no known genetic mutation, it's about primary care, maybe doing a referral into a local family history clinic. That way, so that's usually, particularly Last Trust I worked at, run through the breast screening program associated with that trust. And it's meeting with a family history nurse, specialist generally speaking, and literally laying out the family. So the more information they know about their family, the better, because that will help guide decisions. Obviously, the NICE guidelines have got recommendations too, which kind of fall into that. And then people are placed into high and moderate risk, and based on where their risk lies is whether they'll have, like Amanda's sister, have access to early imaging. So that might be in breast cancer, yearly mammograms and or MRIs. So it is about having those family histories and sending on, if you're not sure, send on a referral, and then it can be up to the secondary care to see whether that's a relevant or appropriate referral if need be.
So Amanda, I really appreciate you sharing your experience so far, and I'm wondering whether there's anything that you'd like to leave GPs with in terms of things that they could do in practice that would really improve care for people going through the experience that you went through. Anything that they might have been able to do to communicate with patients around the symptoms and signs?
When I saw the GP and when she made the initial referral, I did not think that this could be or was breast cancer at all. And I appreciate she was probably protecting me, and maybe also knew that most things that you're referred with, I know Jackie says, is it 9 out of 10 or 90% of referrals aren't actually going to be
into a breast clinic,
aren't going to be a breast cancer diagnosis. I think maybe I understand she was thinking of me and protecting me, and showing great care not to scare me. But I think if she would have said there are different signs and symptoms that could be a breast cancer diagnosis, and I'm referring you because I just want to make sure that this is something benign and not a cancer, because I think when I went to the appointment, I was completely I didn't expect them to say that I had breast cancer. I've never got over the shock of that. And I think maybe just, if that would have been communicated, that we could be looking at a breast cancer. We hope we're not, but this is why I'm referring you to investigate. That's not to say that what she did wasn't right, but I think I had no idea that they were going to say that I had breast cancer. I was never going to be prepared.
I think your age too, you were 42, so I think people just assume that breast cancer is an older person's disease. That's why the screening program runs, because it actually most commonly does affect those 50 and above. But we are seeing it more and more in younger women. There was an article published in the European Society of Medical Oncology, the ESMO, this week, that highlights that actually there has been a 20% increased risk, obviously over the whole of Europe, in breast cancer patients. And we see that here at Future Dreams, where generally speaking it's like younger community, and it's awful, and you get the same conversations. I don't have a family history. I didn't know I can get it in my 20s, 30s, early 40s. But I guess it's just about having those conversations about people knowing they're normal, actively encouraging about every sort of interaction you have with them, that breast checking or chest checking, because again, it can affect men as well as women. I had a positive experience last year. I had my smear test, and actually for the first time ever, I'm in my 40s, First time ever a practice nurse has actually actively asked me, do I routinely self-check? So I've had so many interactions during that time that not one person until last year had sort of actually asked me, am I self-checking? And I thought, wow, that was actually really positive for me as somebody who promotes self-checking and breast cancer. I thought that was really great. But it was going through knowing what the 9 symptoms are. I think everybody in their head thinks it's just a small pea-sized lump in the breast tissue. But actually, we know it's not. It could be lots of different size, shapes. It could be, for some people, as high as their collarbone. Just getting to know that nipple changes, nipple discharge, skin colour changes. If their skin texture goes like yours did, it starts dimpling, that peau d'orange, that orange peel. There's rashes, there's old swellings that kind of don't subside. But it's just having those conversations of what to look out for as often as you can get them in. I appreciate it's hard when somebody's coming in with a throat infection or tonsillitis or something like that to get those conversations in.
If a GP is wanting to remind somebody to self-check, what would you tell them to tell patients in terms of technique, when to do it, specific points during their menstrual cycle?
So I would say is encouraging people to self-check if they're getting regular periods, day 1 or day 2, once their period starts, because that's when their breast tissue is going to be under the least influence of hormones, if you like. But if somebody doesn't get regular periods or male, then as a calendar day of the month, a lot of other charities do Feel It on the 1st, which is an amazing campaign. It kind of has a ring to it. Copperfield are out there. They do a free text message reminder service. So you just go onto their website, pop your phone number in. Every month you'll get that text reminder. But for me, it's encouraging people to start as high as their collarbone. I instruct people to start from the breastbone, up small circles towards their shoulder until they hit breast tissue. And then I kind of, for analogy reasons, use a clock. So you're going using 12 o'clock, 1 o'clock, 2 o'clock, right back to 12 o'clock. So you've actually checked the whole breast. Remind people to check behind the breast tissue. So I think people, when you use their clock analogy, they stop just as they get to the nipple, but they need to check it. And to make sure they're checking under their arms. And obviously to do it both sides. They should be looking in the mirror as well for those physical changes, because, if you're just looking down, you may not see what's underneath the breast. Using the mirror, arms down by their side first, move to their hips, and then arms above. Because like Amanda, it wasn't until she moved her arms above that she actually noticed those skin changes. And then in the shower or laying down, whatever feels comfortable. They have to be comfortable with what they're doing. And arm above the head, because that again changes position of breast tissue as well. So as long as it's resting comfortably. And when they're checking their armpit, to move their arm by their side. But there are so many videos out there that do it. We're releasing one this week of me showing people how to self-check. Copperfield do it, Black Women Rising do it. So if people want a visual aid, I think it'd be signposting to ourselves and other charities out there who are talking people through how to check. And I think for us, it's encouraging people to know what their normal is, because no two people are the same. And sometimes no two breasts are the same, even on one person. And to reach out to primary care if they are concerned, to open those conversations.
So I'd just like to add to that I think when you're waiting for your appointment at the GP surgery, having things on notice boards. Do you check yourself? This is how to check, leaflets showing that. Appreciate time is tight and you can't always talk about and explain everything. But even having those visual aids when you're waiting in the doctor's surgery, someone noticing that, and that might start the conversation as well when you go into your appointment.
Was there anything, Jackie, that you wanted to leave us with in terms of key points for primary care that they might be able to take into their practice?
I get asked about risk factors all the time, and there are things that people can't control. Things like age, genetics, when their period started and when they go into menopause, ethnicity, history, previous cancers. That's what somebody can't control. But I like to focus on what people can control. So getting those messages about healthy lifestyle. We know that obesity can increase, particularly after menopause. And I use the Women's Health Concern infographic. It's great at explaining risk to people. So you take 1,000 women between age 50 and 59. For somebody who's obese, so the general population is there's 23 people out of those 1,000 will get a breast cancer diagnosis in that age group. But if somebody's obese with a BMI higher than 30, there's an extra 24 cases in that field. So it's just using infographics. We've got to remember that people take in information in lots of different ways. So weight management, alcohol intake, smoking, exercise. And that's not just for cancer, is it? That's for diabetes risk, that's stroke, that's heart disease. So it filters through all kinds of remits of primary care. But having infographics so people can actually look at things and actually have that diagram there so that people can actually make choices and doing what they can control it, because sometimes we can't control it, but there are factors we can do to improve our risk.
So I'm pleased now for the second part of this podcast that I'm joined by Catherine Priestley and Laura Price from Breast Cancer Now. Breast Cancer Now is a research and support charity offering information and support to anyone affected by breast cancer or breast health, as well as funding research on prevention, detection and treatment. Catherine Priestley is a senior clinical nurse specialist for secondary breast cancer, and Laura Price is the host of Breast Cancer Now podcast and author of the novel Single Bald Female, which was inspired by her experience of being diagnosed with breast cancer in her 20s. Laura now lives with secondary breast cancer and is here to share her experiences. So secondary or metastatic breast cancer can refer to de novo breast cancer that's diagnosed at the same time as the primary breast cancer or before the primary breast cancer has been discovered. But more commonly, it's a recurrence of disease that occurs years or sometimes months after treatment for primary breast cancer, with the cancer having spread to distant organs. And that's what we're going to focus on now. So we'll be talking about symptoms and signs of recurrence and how to spot this. Secondary breast cancer is treatable, but currently not curable, although many people are now living much longer and with a good quality of life. So welcome to the podcast, Catherine and Laura. And Catherine, can you tell us a bit more about diagnoses of secondary breast cancer? Who is at highest risk and where secondary cancers most commonly appear?
So secondary or metastatic breast cancer is breast cancer that has spread to the distant organs, as you've already said. So it's really important that we do know those signs and symptoms so we can give that support and knowing where to look for those symptoms. So in theory, secondary breast cancer can spread anywhere in the body, but typically it's bones, liver, lung and brain. And some cancers do spread, or some type of breast cancer does spread to the peritoneum, so around the gut and the gynecological tissues, and that's typically lobular breast cancer. From a risk perspective, the reality is that anyone with a diagnosis of primary invasive breast cancer is at risk of developing secondary breast cancer. Everyone's risk of their breast cancer recurring will differ, and that depends on the details of the cancer. So things like the size, the grade, the extent of the lymph node involvement, and also on the biology and the subtype of the cancer. So, for instance, triple negative breast cancer, we know has a higher risk of recurrence in the first few years, 3 to 5 years type time frame. Breast oncology teams can calculate the probability of someone's risk of their disease recurring by using some predictive tools, and they're quite commonly used in oncology clinics, and quite often that risk is discussed with patients. And we know that some people will be high risk but probably won't experience recurrence. This is a probability, it's not a guarantee. And some people who have a very low risk of their breast cancer recurring will have a recurrence, they will experience that recurrence. So I think the message we need to be aware of is that everyone's risk is different, but even if it's low risk, it's not no risk.
Thank you very much, Catherine. What are the symptoms that somebody might be reporting if they've got a secondary breast cancer or if they suspect they may have a secondary cancer?
Yeah, so in the common sites I've just mentioned, bone, lung, liver, brain and the abdomen, then there are quite a few symptoms, but probably the main symptoms for each one are things like bone pain. So that often is with the need for more analgesia. It might be that the patient says it's worse when they're laying down or at night time. There might be hypercalcemia, which is picked up in a blood test, and the symptoms of this may be some patients do experience a pathological fracture, and then there's all the neurological symptoms and pain symptoms that can be associated with malignant spinal cord compression. For lung, then we're talking about things like new shortness of breath, chest pain or chest tightness, a dry cough maybe, hemoptysis sometimes, and sometimes also voice change. The laryngeal nerve can actually be affected. There can be a palsy there, so there can be voice changes for some people as well. From a liver point of view, then right upper quadrant pain or generalised abdominal pain. Sometimes that's right shoulder tip pain as well. Nausea, loss of appetite, weight loss, hiccups are quite often one thing, as well as jaundice as well. And for the brain, there's lots of obvious signs and symptoms for there, so severe or ongoing headaches, nausea and or vomiting. Quite often people find that's worse on waking in the morning. They might get unilateral weakness or numbness, and they might also find that they're dizzy or they've got an unsteady gait. Seizures are a key symptom for some people depending on where their brain mets are, and then vision or speech disturbance as well. Some people also experience a bit of confusion, but often memory problems, and probably later on more likely personality changes as well. I think the one set of symptoms that people are not necessarily always familiar with as far as breast cancer and its spread is concerned is what I've mentioned already. So the abdomen, the peritoneum, and this is more common with a history of lobular breast cancer, as I mentioned. So abdominal pain is one symptom which can be caused by all sorts of things, obviously. Feeling full quickly when eating, feeling bloated, and quite often people describe changes in their bowel habit, including constipation and often also frequency of passing urine. But there are also those general just symptoms of potential spread to multiple organs, so persistent nausea, fatigue, any enlarged lymph nodes, and then unexpected weight loss as well, which are just general sort of symptoms, not specific to places. So our message really from Breast Cancer Now is for patients to report any new and any persistent symptoms with no obvious cause. As I said, we know that many symptoms of recurrence are the same as or similar to the effects experienced by people who are still on treatment for their primary breast cancer maybe, or possibly late effects after they've finished their treatment. So it is really difficult. We get lots of calls and speak to lots of people at Breast Cancer Now about the difficulty of being able to spot the difference between side effects and symptoms of spread. But it's really important that both patients and healthcare professionals, the ones that they come into contact with, have an understanding and know what signs and symptoms to be aware of after breast cancer. But it's really key that they are checked out, because we know that sometimes patients not reporting them will mean that they do have a diagnosis of secondary breast cancer, and then their disease is really advanced, or perhaps it means that there are delays in the GP actually getting them checked out, and therefore their diagnosis and that access to treatment and support as well.
Thank you. And Laura, could I bring you in now and ask if you're happy to share some of your experience and whether what Catherine has said has chimed with your experience of being diagnosed with secondary breast cancer?
Yes, absolutely. Hi. So I was first diagnosed with breast cancer in 2012 when I was 29. So that was when I had my primary cancer through the quite standard way of finding a lump, and that was invasive ductal carcinoma. And I had chemotherapy, wide local excision surgery, and radiotherapy. And then I started on tamoxifen. And then it wasn't until almost 10 years later that I started to get symptoms of secondary breast cancer. I had a recent change in drugs, which meant that I had some breast pain. But aside from the breast pain, I also had chest pain. So it spread to my sternum bone. And I had a number of different symptoms. So I had what felt like a bruise on my breastbone. So if I touch it with something, or if someone would hug me, or if I was wearing a necklace, it would suddenly smart quite severely. So I had that, but I also had some aching. And then I'm a swimmer, and when I would swim front crawl or push myself out of the pool with my arms, it would really, really hurt the bone. However, when you've had breast cancer, if you do know about secondary breast cancer, you Google the signs and symptoms and you see some of the things that Catherine just mentioned, which are, does the bone pain feel worse at night? No, it didn't in my case. Does it feel worse when you're lying down? No, it didn't in my case, apart from when I was turning over in the night, at which case it really hurt because it was sort of squeezing my chest together. And part of the problem for me was that I had muscle pain at the same time, and I also do a lot of exercise, so I thought, could it be related to that? Could it be hormones? I also had some pains in my breast, so there's a real mix of symptoms. And I reported to my cancer hospital team that I thought there could be a chance that it had spread to my bone, to my sternum bone, and they did a breast ultrasound, because at the same time I was reporting breast issues. And I had also Googled other options that it could be, and one of them was costochondritis, which is inflammation around the ribs and around that area. And it was agreed by the team that that was probably what it was, and I got sent away. And then a few months later, it was worsening. And I was also experiencing a little bit of difficulty breathing and a sort of sharp pain in the chest as well. So I did lots more Googling. I went back to the team. They did another breast ultrasound, but still didn't give me a scan of my bones. I then got discharged back to my GP. The GP did an X-ray, and then I expressed again that I thought it could be metastasis to the bones. And my GP referred me back to the oncology unit, and they finally did a thorax MRI, which then revealed a large mass on my chest bone area. And then we then had a PET CT, and that revealed that it was quite a large metastasis to the sternum bone. So there was a 9-month delay in my diagnosis. And when you look back at it, I had pretty clear signs and symptoms, but because there was mixed in with some other muscular and hormonal and breast pain and a possible cyst in one of my breasts, I think it had kind of got lost there. But I was fortunately, the 9-month delay in diagnosis didn't make the hugest amount of difference to my treatment, because it was still in time. It still hadn't spread to any of my other bones or organs, and it was still in time to put me on a course of treatment, which was letrozole, Zoladex and ribociclib, which completely shrunk the tumour. And I was very, very lucky because I was able to have surgery to remove my whole sternum. So that was a sternum resection. And it's now been 3 years since my diagnosis. And as it stands, the cancer is still asleep, and I hope it continues that way for a long, long time. But I do my best now to share signs and symptoms with other people and to sort of raise awareness of secondary breast cancer, particularly in people who have had primary breast cancer and might be years out from it and not necessarily aware of the signs and symptoms.
So it sounds like you obviously did a really good job advocating for yourself, and I'm glad that in the end you were able to get that diagnosis and it didn't affect the course of your treatment. But yeah, that sounds like a really, really difficult experience to have to keep pushing for that length of time to get that diagnosis. I'm interested in, obviously, what we've spoken a bit about with Catherine, and that you've mentioned the challenges in how non-specific the symptoms can be. And you mentioned the bone pain obviously being a significant symptom for you. And I'm just wondering whether you can talk a bit more about that, about what GPs might be able to ask their patients in order to pick apart the symptoms, I suppose, to find what are the important things that they need to be focusing on.
That's a really interesting question. I think for me as a patient, when you read bone pain, is it bone pain that gets worse overnight, etc., you don't know what bone pain is if you've never had bone pain. And even now, 3 years after, I can't really describe what bone pain feels like. And you second guess, and then you start to doubt yourself, because you're like, well, is this bone pain or is it muscle pain? Like, I thought it could even be to do with my pecs. I just was really confused about what bone pain was. The real thing to root out from the patient would be, is this something really different from anything you've ever experienced before? Because in my case it was. And also, is it something that is ongoing and changing and worsening? Because in my case, you know, we've all had a bruise, we've all been able to touch the skin and feel it smart. But to have that there and to on my chest bone, and to get to the point where someone hugs me and I go, oh, because it's so painful, and also to sneeze and cough. So I would say specifically to the sternum bone, and I haven't had METs to any of my other bones, fortunately, so I can't speak to those signs and symptoms, but definitely ask, does it hurt when you cough? Does it hurt when you sneeze? Because those two things were incredibly severe with the sternum pain. And then you could also do things like you could do a front crawl motion, because that would certainly hurt. And also to turn over on my side and sort of push the breasts together would also be really painful. So anything that's kind of putting pressure on the sternum bone would generate that bone pain. Other questions to ask would just be, has there been a change in your medication? Because in my case, there had. And if a patient is talking about multiple different signs and symptoms, so in my case, breast pain, chest pain, there were two totally different things, but they were happening at the same time. And so I think if you can really, really listen and say, okay, let's talk first about the breast pain. What exactly does the breast pain feel like? when does that hurt you and how does it hurt? And then, okay, now let's talk about the chest pain. What are the times that you notice that, and in what way does it hurt? And just try and get them to describe the individual things, because I think that's partly what led to the confusion in my case and the misdiagnosis, was because we were talking about two different things, and for some reason the breast pain got prioritized and the chest pain got ignored, even though I had said suspected metastasis to the bone. So yeah, just lots of questions and lots of listening, I think.
You mentioned that there was a 10-year gap between this experience and your primary diagnosis of breast cancer. Had you had any other experiences in that interim where you had concerns about secondary breast cancer, where you'd presented to your GP, and how was that handled?
Yeah, I had quite a few over the years, actually. So probably within a year or two of my initial surgery, I had a cyst under the armpit, which it was on the scar where my lymph nodes had been taken in my original surgery. And I had a cyst that just suddenly grew really big, filled with fluid, and was really sore. And, you know, when you're that soon out of your breast cancer diagnosis, you really worry that that is something. And that was dealt with really well, I think, because when you are discharged from primary breast cancer treatment, I think you're usually given a direct line with your hospital. So I did report it in the first instance to my GP, and because I'd had breast cancer, it was quite clear that I needed to be referred back, and that was just a simple thing that they were able to drain. And over the years, I also had various different breast or chest pains and worries. Often I would go to my GP and say, I've got such and such a thing, and I'm worried that it's secondary breast cancer. Like I had a hip pain, for example, which more often than not was related to running or some kind of sport. And I would say that my experiences and the responses over the years at the different GPs that I've had from living in lots of different parts of London over the years have been really different. So I've definitely been made to feel that I was being a bit paranoid. I've certainly often cried in a GP's office because I felt, not in a nasty way, dismissed, but just a little bit like not taken seriously enough. And I've had ones saying, oh, no, you don't need to worry. It won't be anything to do with that. It's just, you're just hormonal or whatever. I've definitely had that quite a lot over the years. The great thing was that with the Royal Marsden, I always had access to the open access line where you could call the nurses, and I called them many times over the years, and they always listened, and they were always really brilliant to talk to. So I think if I'd been to my GP about something, but it was something that I was worried about breast cancer wise, I could also talk to that open access line for a sort of a second opinion if I needed it.
So in terms of thinking about what primary care might be able to do differently, we've talked about the really active listening and detailed kind of questioning and history taking, and then you've just talked then about really taking your anxieties seriously.
I think also just taking the time, and I know time is always massively short for GPs, but I've moved around a lot in London in the last 20 years, as a lot of people do throughout their 20s and 30s. And so you've got a lot of history behind you when you've had breast cancer and you've gone through breast cancer treatment, and then you've moved, and then you've moved again, and then you've moved again. And I think taking the time when someone goes in with a sign or a symptom and mentions that they've had breast cancer, do you then take a moment to, as soon as someone says cancer, do you then take a little bit of extra time to read through their notes and talk through with them and say, okay, when did you have the breast cancer treatment? What other issues or signs and symptoms have you had since then? What drugs have you been on? What's your family history? And just dive into it a little bit further, because so many patients, including me, feel like we're taking too much of our GP's time, because we know time is so short, that I will sometimes have another sign or a symptom in the back of my mind, but I don't want to waste their time or take too much time by mentioning that. And actually it might be that I don't know that my breathlessness is also a sign that they could put these two things together and say, oh, that could be secondary breast cancer. So, you know, in those patients' cases, is it worth taking that extra couple of minutes to say, have you got any other signs and symptoms at the moment? Is anything else that's bothering you? And then also just really asking about timeframes. I know I, as a patient, always write down, I make notes all the time in my phone of how I'm feeling day to day. So when I used to have periods, I would write about what different pains I had during that point in the cycle, when I have a migraine, when I have a headache, all of these things, so that if my GP or whoever then asks me, how long have you been experiencing this sign and symptom for, I can tell them exactly, well, it started in October. And so when I did get this diagnosis 9 months after I'd started experiencing symptoms, I can now go back into my phone and say, on this day, I went for a run and I felt like my chest really, really hurt. And on this day, I had difficulty breathing. And I've got this whole record of these signs and symptoms. So perhaps GPs could also encourage people to make those records, and then you could get them out when you're in the GP and just talk through what you've been experiencing. But I guess time is a really key thing.
Yeah, absolutely. Has it been your experience then, as you've moved around different GP surgeries, that you have had to be the one to say, I have had breast cancer, I've had breast cancer treatment in the past? Or have you ever had experiences where primary care have proactively brought that up and that's already been noticed from your notes?
My memory is so bad at the moment because menopause and so many other things going on, but it really depends on what the issue was. But if I was going in about something that I was worried could be to do with breast cancer, I would say, and I've had breast cancer, so I'm more worried than your average patient. And I think that's why my case is a difficult one, because most of my misdiagnosis was actually down to the hospital, whereas my GP took me very seriously in this case, and she was the one who referred me back to the hospital and said, look, you know, I think you've got legitimate concerns that this is secondary breast cancer. But it's really, really tricky because it's so different everywhere you go. But if you're the further away in the past your breast cancer experience is, probably the less likely your GP is to see that straight away on your notes. So it's just always worth asking, have you ever had cancer? Have you ever had breast cancer?
We've talked a bit about the symptoms and the variety of symptoms. Catherine, was there anything that you wanted to add that GPs could be doing?
GPs are seeing so many patients. There's always going to be a lot of patients of theirs that have had a breast cancer diagnosis and treatment for that breast cancer. So if you know that that patient has had a history of breast cancer, just checking in with them, how they're doing, if they got any new symptoms, not to worry people, but just asking over overall well-being, anything new, anything that's worrying about them about that, and checking that they have got the information that they need, so that they're aware of the importance of looking out for it, and encouraging them to come and report changes to them is also helpful, because we get so many calls on our helpline at Breast Cancer Now, our free helpline, where people say, I don't really want to trouble my GP, or I don't really want to call my hospital team because I know they're so busy and I know they push for time, so I don't want to waste their time. They've got so many other people like me that were going through treatment, and that's where their sort of focus lies. So just encouraging people to be open and to bring those worries to them. Not everybody gets that information about the changes to look for after breast cancer, so we've got some great information at Breast Cancer Now on the signs and symptoms of breast cancer, secondary breast cancer specifically. Some GP surgeries might even have received packs from us recently with this information in, because we're doing quite a lot of proactive engagement with GP surgeries and sending out in that information. We've also got information on signs and symptoms of recurrence quite more broadly, so that includes local recurrence. So having that to hand, displaying it in the GP surgeries, having those conversations. But I think going back to what Laura says, and from a specialist nurse's point of view, and I speak to many secondary breast cancer clinical nurse specialists who care for and support this patient group, they'd be keen to ask GPs just to recognise those alarm bells a bit sooner, even if it is, like Laura says, that it's a long time since that patient had. It's not unusual these days for people to be beyond a decade, as we've said, and sometimes 2 decades when their breast cancer comes back. We're not really sure why that happens. We've started to look a little bit more about dormancy of cells and that type of thing, but it can happen. And just be a bit more curious. So listen, ask those questions, and be a bit more suspicious I'm tempted to say, think about ruling it out rather than ruling it in and thinking, no, it can't be that. It's quite a long time since that. I'm sure it can't be that. And just make sure that they're also aware of the pathway to follow so that symptoms can be assessed when they've got a patient in front of them. They think, yeah, we need to check this out. And remembering that low risk is not no risk. Those would be my tips.
Was there anything that you wanted to add to that, Laura?
Yeah, there's a few. I mean, something Catherine just said made me think also paying extra attention when someone is particularly high risk. For example, I was diagnosed when I was 29 with primary breast cancer. I believe that makes it fairly likely that it will come back when you're diagnosed so young. Also, people with triple negative breast cancers and HER2 positive cancers, there are so many different types that are perhaps more likely to come back. But a few other things I would say would be, if a patient has a hunch, we often get people say, I just had a feeling and that's why I went back. And I think, obviously there are cases where a patient has a feeling and actually they're just paranoid or, they're just extra worried and anxious. But if someone has a really strong feeling and they go to their GP, they come back and they say, I've got a really strong feeling, I'm sorry to bother you. Just listen to them, ask them why they've got that feeling. There's usually a reason, and if it's nothing, then there was no harm in listening. And then be aware that it can come back many years down the line, as it did in my case. And then there's another one, which I do, which is I go in, I often have my own answers and my own alternatives. So one of the reasons I think my team decided that it was costochondritis was because I said it was costochondritis. So I went in and said, I'm worried that it's spread to my breastbone, but it could easily be costochondritis. And I do loads of exercise. So it could be this and it could be that and it could be this. My team should have said, do you know what, we'll get you a PET CT scan because let's rule it out. And I hadn't had a PET CT scan for the whole 10 years. I'd had annual MRIs, but I hadn't had any bone scans. And so I think similarly, while I say listen to a patient, if a patient is making up their own self-diagnosis, they think it's this and they think it's that, do listen, but also say, do you know what, just in case, I'm going to put you through for a scan because you might not be right. So I think listen, but also take with a pinch of salt if patient self-diagnoses something that's actually much less serious than the thing that it could be.
Thank you, Laura. Yeah, and it's interesting actually that you talk about the sort of the hunch that patients can have, because that's also something that we hear GPs talk about a lot, the sixth sense that comes with experience, particularly when you're talking about really non-specific symptoms that often a GP might just get a feeling they can't put their finger on. That's a really important thing and something that's probably not talked about enough in medicine, because we like to talk about the sort of specifics, don't we? But of course, there's a human interaction element to it as well, which is really important.
I think also just paying attention to, have they had a recent change in medication? For example, most people are on tamoxifen now for 10 years, but have they recently stopped tamoxifen and therefore is their body flooding with estrogen? And then also family history. My grandmother had had breast cancer in her 30s and died in her early 40s. So pretty strong. And at that point, I later found out that I have the PALB2 genetic mutation. But at that point, we didn't know that, and that wasn't in my medical history. But just me saying, well, my grandmother had breast cancer in her 30s in the 1960s should be a strong reason for us to say, okay, perhaps not costochondritis. Let's do some more tests. And I think all the evidence weighs up to say higher likelihood that this could be a cancer that has spread.
So Catherine, can you talk a little bit more about delays to diagnosis?
Yeah, sure. So in 2019, Breast Cancer Now surveyed, I think it was over 2,000 people in the UK living with secondary breast cancer about their experiences, and that included their experience of presenting with symptoms to their GP. And although it's quite a few years ago now, anecdotally, we know that these experiences haven't really changed. And what the survey told us was that about 1 in 4 respondents who'd previously been treated for breast cancer, so they'd had treatment for primary breast cancer, visited their GP 3 or more times with their symptoms of secondary breast cancer before they got a diagnosis. So that delay obviously makes a difference to people's anxiety, the way that they feel, the worries, that all of those worries and the things that Laura had gone through in the meantime. We really want to help primary healthcare professionals across the UK We'll see loads of people who've been treated for primary breast cancer to become familiar with those signs and symptoms, because although we currently don't have evidence that finding secondary breast cancer disease makes a difference to overall survival, we do know that many more people are living much longer, even though we haven't got the accurate statistics to back that up. But we know that it's really crucial that those people that get that diagnosis are, when they're diagnosed promptly, it means that they can begin treatment, they can access symptom control, and they can get the care that they need as quickly as possible. And that can make a big difference into their ability to maintain as good a quality of life as possible for as long as possible. So actually getting that diagnosis sooner would mean better access to all of those things and mean that people can live and live well for as long as possible.
If anyone has more podcast listening capacity and time, then we do, on the Breast Cancer Now podcast, which I host, interview loads and loads of people with both primary breast cancer and secondary breast cancer. And if any of your listeners have time to listen to a few episodes, you'll just get so many different stories of people who found a rash under their armpit, or people who found a dimpled nipple during pregnancy or whatever. And you just realize how many different routes there are to discovering breast cancer and getting that diagnosis. So you just hear it from the patient's point of view as well. So if that's of interest to anyone, then just look for the Breast Cancer Now podcast.
We speak to lots of people who want or need information and support after breast cancer, after their treatment for breast cancer, on a helpline. We do sometimes have healthcare professionals ring us as well, and we have lots of people ring us about breast health, but I think most people after treatment are ringing because they want support after treatment. They're really struggling. So we've got written information in print and on the website about follow-up, so what to expect. It's really helpful when patients know what to expect and when to expect, so they can follow that up if they haven't got their appointment for their annual mammogram, but also know who to contact if they've got symptoms. So a lot of people do go to their GP, but a lot of people have also got open access to those nurses that Laura mentioned, and that can be a really helpful way to get symptoms that might be symptoms of recurrence checked out and done that a little bit faster. But we've got some good information about that and also the signs and symptoms of recurrence as well. So people can find out more about that on our website or by calling our helpline too.
So thank you to all of my guests for today's podcast. And you can find more information about where to signpost patients to for support, as well as further reading for healthcare professionals in the show notes for this episode. And don't forget that you can go to mimslearning.co.uk as well to click through on the module for this podcast and claim your CPD certificate. Thank you for listening, and we'll see you next week.